Good morning and welcome everyone. This is Grace Lee, Chair of the Advisory Committee on Immunization Practices. Today is Wednesday, October 25th, 2023, and I am pleased to call today's ACIP meeting to order. I'll turn it over first to Dr. Melinda Wharton to begin with our purpose and our process this morning, as well as any brief announcements.
Thank you, Dr. Lee. Good morning. Next slide, please. Good morning, and welcome to the October 25th, 26th, 2023 ACIP meeting. Copies of the slides that are being presented at today's meeting are available or will be available soon on the ACIP website. A few notes on meeting logistics for those who are listening in on the Zoom line. Please keep your line muted until you're called on for discussion. When Dr. Lee opens the meeting for discussion, please use the raise hand function in Zoom to virtually raise your hand if you wish to be recognized. During the discussion, Dr. Lee will take questions first from voting ACIP members and then, as time allows, from ex officio and liaison representatives. Please keep your video off until we get to the votes. We will ask ACIP members to turn their video on during voting. The Advisory Committee on Immunization Practices is, at its heart, a public body, and engagement with the public and transparency in our processes are vital to the committee's work. For this meeting, we will be holding 2 oral public comment periods. The first will occur today at approximately 12:50 p.m. Eastern Daylight Time. There will be a second oral public comment period tomorrow at approximately 10 a.m. Eastern Daylight Time. To create a fair and more efficient process for requesting to make an oral comment, we ask those interested to submit a request online in advance of the meeting. We give priority to advance requests, and if there are more requests than can be accommodated in the allotted time, we select speakers through a blinded lottery. The 14 speakers selected by lottery for this meeting have already been notified. We thank all those who requested an opportunity to make a public comment. Members of the public also had the opportunity to submit written public comments on issues coming to ACIP via regulations.gov. The docket number for today's meeting is ID CDC 2023-0079. More information on the public comment process can be found on the ACIP meeting website. As noted in the ACIP Policies and Procedures Manual, members of the ACIP agree to forgo participation in certain activities related to vaccines during their tenure on the committee. For certain other activities that potentially enhance a member's expertise while serving on the committee, CDC has issued limited conflict of interest waivers. Members who conduct vaccine clinical trials or serve on data safety monitoring boards may present to the committee on matters related to those vaccines, but these members are prohibited from participating in committee votes on issues related to those vaccines. Regarding other vaccines of the concerned company, a member may participate in discussions with the provision that he or she abstains on all votes related to the vaccines of that company. At the beginning of each meeting, ACIP members state any conflicts of interest. Dr. Lee, that concludes my opening comments. Thank you.
Thank you. We'll now proceed with roll call. For the ACIP members, I will ask that you state your name, your affiliation, and whether you have any conflicts of interest. We'll go in alphabetical order. So this morning we'll start with Ms. Bata.
Good morning, Lynn Bata. I am the Public Health Nurse Immunization Clinical Consultant at the Minnesota Department of Health, and I have no conflict.
Thank you. Dr. Bell.
Beth Bell, Clinical Professor, University of Washington, no conflicts.
Thank you. Dr. Brooks.
Oliver Brooks, Chief Medical Officer, Watts Healthcare Corporation, South Los Angeles. No conflicts. Good morning.
Morning, and thank you. Dr. Chen.
Wilbur Chen, Professor of Medicine at the Center for Vaccine Development and Global Health at the University of Maryland School of Medicine. I have no conflicts.
Thank you. Dr. Sineas.
Sybil Sineas, Associate Professor of Medicine and Pediatrics at the Warren Alpert Medical School of Brown University, and I have no conflicts.
Thank you. Dr. Daly.
Good morning, Matt Daly. I'm a practicing pediatrician at Kaiser Permanente, Colorado, also a senior investigator in the Institute for Health Research at Kaiser, Colorado, and I have no conflicts of interest. Thanks.
Thank you. Dr. Cotton.
Good morning, Camille Cotton. I am the Clinical Director of Transplant and Immunocompromised Host Infectious Diseases at Massachusetts General Hospital and Associate Professor at Harvard Medical School. I have no conflicts of interest. Thank you.
Thank you. Dr. Lair?
Good morning. I'm Jamie Lair in private practice of family medicine in Ithaca, New York, and I have no conflicts of interest.
Thank you. Dr. Long?
Good morning. I'm Sarah Long. I'm a professor of pediatrics at Drexel University College of Medicine and a subspecialist in pediatric infectious diseases, and I have no conflict to disclose.
Thank you. Ms. McNally?
Good morning, Veronica McNally, president of the Franny Strong Foundation based in Michigan, and I have no conflicts.
Thank you. Dr. Paling?
Good morning, Kathy Paling, professor of pediatrics and epidemiology and prevention at Atrium Health, Wake Forest Baptist, Wake Forest School of Medicine. I have no conflict. Thank you.
Thank you. Dr. Sanchez?
Good morning, Pablo Sanchez, professor of pediatrics at the Ohio State University College of Medicine, neonatology and pediatric infectious diseases at Nationwide Children's and in Columbus. I have no conflict.
Thank you. Dr. Talbot?
Good morning. This is Kip Talbot, professor of medicine and infectious diseases at Vanderbilt University Medical Center. Thanks.
Conflicts, Dr. Talbot?
Sorry, I always forget. No conflicts.
Thank you. And this is Grace Lee, professor of pediatrics at Stanford University School of Medicine and chief quality officer of Stanford Medicine Children's Health, and I have no conflicts. And so for our committee today, we have quorum and we're able to proceed. We'll move on to our ex officio and liaison members. I'll announce the organization name and just please indicate if you're present and your first and last name. Centers for Disease Control and Prevention.
Dimitri Daskalakis, present.
Thank you. Centers for Medicare and Medicaid Services.
Good morning, Mary Beth Hance, present for CMS.
Thank you. Food and Drug Administration.
David Kaslow, present.
Thank you. Health Resources and Services Administration.
Commander Reed Grimes, present.
Thank you. Indian Health Service.
Matthew Clark, present.
Thank you. I know Dr. Beigel might be having audio issues, but I'll see if he's available to speak up. National Institutes of Health. Okay, we'll come back to you. Office of Infectious Disease and HIV/AIDS Policy.
Commander Valerie Marshall, present.
Thank you. Let's move on to the liaison representatives, and we'll come back to Dr. Beigel in a moment. We'll go on to American Academy of Family Physicians. American Academy of Pediatrics. American Academy of Pediatrics Red Book.
David Kimberlin, AAP Red Book editor.
Thank you.
AAP Sean O'Leary, present, sorry.
Thank you, Dr. O'Leary. American Academy of Physician Associates.
Good morning, Marie-Michelle Leger, present.
Thank you. American College Health Association.
Sarah Lee, ACHA.
Thank you. American College of Nurse Midwives. American College of Obstetricians and Gynecologists. American College of Physicians.
Good morning, Jason Goldman, American College of Physicians, present.
Thank you. American Geriatric Society.
Ben Schmader for AGS.
Thank you. America's Health Insurance Plans.
Good morning, Jessica Grab, present.
Thank you. American Immunization Registry Association.
Good morning, Rebecca Coyle and Courtney Londo.
Thank you. American Medical Association.
Sandra Freihofer, representing the American Medical Association.
Thank you. American Nurses Association. American Osteopathic Association.
Stan Grog, good morning, I'm present.
Good morning and thank you. American Pharmacists Association.
Good morning, Kelly Good, present.
Thank you. Association of Immunization Managers.
Molly Howell, representing AIM.
Thank you. Association for Prevention, Teaching, and Research.
Good morning, Christy Mullen-Jeffel, representing APTR, present.
Thank you. Association of State and Territorial Health Officials. Biotechnology Innovation Organization.
Good morning, Phyllis Arthur and Emily Acker, representing Bio.
Thank you. Council of State and Territorial Epidemiologists.
Christine Hahn, present.
Thank you. Canadian National Advisory Committee on Immunization.
Kelly Deeks, NACI, thanks.
Thank you. Infectious Diseases Society of America.
Jim McCauley, present.
Thank you. International Society for Travel Medicine.
Elizabeth Barnett, here for ISTM.
Thank you. National Association of County and City Health Officials.
This is Matt Zahn, present.
Thank you. National Association of Pediatric Nurse Practitioners.
Good morning, Patsy Stinchfield, and I'm joined today by Dr. Dana Deshawn, and this is my last meeting, so she'll be our liaison for NAPNAP going forward. Thanks.
Thank you, and thank you for your service for the very many years I've been on. National Foundation for Infectious Diseases.
Good morning, this is Marla Dalton representing NFID.
Thank you. National Medical Association.
Good morning, Patricia Whitley Williams, NMA.
Thank you. Pediatric Infectious Disease Society.
Good morning, Grant Paulson, PIDS. Thank you.
Morning and thanks. Pharmaceutical Research and Manufacturers of America.
Good morning, Monica Mercer, present.
Thank you. Society for Adolescent Health and Medicine.
Hi, it's Amy Middleman representing SAM.
Thank you. And Society for Healthcare Epidemiology of America.
Preeti Mehrotra, present.
Thank you. We'll go back and ask if anyone has been able to log on and wishes to announce themselves. So I'll start with National Institute of Health. Okay, we're still having audio connections. Has anyone else joined from our liaison organizations? Okay, I don't see any hands raised. So with that, we are ahead of schedule, but that is a good thing because we have a packed agenda today. So we will plan to move on to our first session of the morning, which is on meningococcal vaccines. I'd like to introduce Dr. Kathy Paling, who is chair of the meningococcal vaccines work group, who will provide an introduction and overview of today's session. Dr. Paling.
Thank you, Dr. Lee. Good morning. So it is my honor to introduce the ACIP meningococcal vaccine work group. Next slide, please. So first of all, I want to start with the many people that have contributed to this work. A special thanks to my co-ACIP members, the ex officio work group members, the work group liaisons, consultants, and special thanks to the CDC contributors who've really worked hard to get the data we needed to guide this discussion, and then our grade and ETR support. Next slide, please. In June, we presented these same questions, so I wanted to remind everybody as an orientation, the policy topics under consideration by the work group regarding Pfizer's pentavalent vaccine are the following 3 questions. Should pentavalent vaccine be included as an option for MenABCWY, MenB vaccine in people currently recommended to receive both vaccines? The second, should pentavalent vaccine be included as an option for people currently recommended to receive MenABCWY only? And third, should pentavalent vaccine be included as an option for people currently recommended to receive MenB only? And remember, this is important because you have to stay with Trumbemba or this. You can't cross your Bs, just as a reminder so everybody's on the same page. It's early. Next slide. All right, so let's summarize what we've discussed before. So in February 2023, we discussed the epidemiology of meningococcal disease in the United States, the Pfizer's MenABCWY vaccine clinical trials, the work group's interpretation of the pentavalent trial data. In June, we introduced the CDC's cost effectiveness model and a summary of the grade and ETR framework. Next slide, please. Okay, so since then, from June to October, the work group has been busy. We got feedback from the June ACIP meeting and really appreciated this. A review of the meningococcal schedule has been postponed to allow for consideration of GSK's forthcoming pentavalent vaccine and availability of data about post-COVID meningococcal epidemiology. So that is taken seriously, but we think that would be the better timing, and not today. Comparisons of the cost-effectiveness models, and there's been updates on the CDC cost-effectiveness model with new price estimates. It should be highlighted that the price for pentavalent before was $40 to $90 more than MenB, and now is similar. So there's been an adjustment. And then we discussed 3 potential recommendation options based on concerns raised by ACIP members in June and the new cost-effectiveness estimates. Next slide, please. So let me summarize where we are. For the question, should the pentavalent vaccine be included as an option for when you got the quadrivalent NB vaccination in people currently recommended to receive both? The answer has been yes, strong consensus. And this is really about when you're 16 to 18 years of age is when this is going to happen. All right, it's really a 16, typically it happens around 16. Should the pentavalent vaccine be included as an option for people currently recommended to receive the quadrivalent vaccine only? And that's really talking about your 7th grade dose. And there's a pretty strong consensus from the group, and this hasn't changed, no. And then this is the one we talked a lot about. Should the pentavalent vaccine be included as an option for people currently recommended to receive MenB only? This is the dose that's typically given just before college or military service. And we did not have a strong consensus. We went from, we became perhaps limited consensus. So we're going to be sharing that data. And we do remember that you can't cross your B's. All right, next slide, please. So today, Dr. Lucy McNamara is going to talk about plan for revisiting the adolescent schedule for meningococcal vaccines, because that is going to be done, though not today. Dr. Ishmael Ortega-Sanchez is going to talk about the comparison of Pfizer and CDC cost-effectiveness analyses for Pfizer's pentavalent vaccine. And remember, there was a change in the estimate of the cost of the vaccine. There's a summary of the ETR and proposed recommendations for the pentavalent vaccine by Dr. Jennifer Collins. And then Dr. Gian Santoli is going to talk about the vaccines for children resolution. And then later today, we will have a vote for the pentavalent vaccine. And if it is approved, there will be following that a VFC vote. I believe I get to turn this over to Dr. Lucy McNamara. Thank you.
Thank you, Dr. Paling. We'll move on to Dr. McNamara, who will be discussing the adolescent schedule.
Great, thank you very much. So yes, good morning, everyone. I'm just going to give us a brief update on the meningococcal vaccine working group's plans for revisiting the adolescent schedule for meningococcal vaccines over the next year. So as Kathy mentioned, at the June ACIP meeting, there was a great deal of interest expressed in revisiting the current meningococcal vaccine schedule for adolescents. And some of the questions that were raised included whether the 11 to 12-year-old dose of MenABCWY is still needed, especially given recent epidemiology with very low disease burden in the 11 to 15-year-old age group. There were also some questions around the shared clinical decision-making recommendation for B vaccines. It was noted that the availability of pentavalent meningococcal vaccines may complicate the shared clinical decision-making discussion for providers, and that some nuances such as the short projected duration of serogroup B protection may be lost when it's possible to give a single injection covering all 5 serogroups. It was also highlighted that opportunities to reduce the total number of vaccines given for instance, by leveraging pentavalent vaccines, would be appealing if it is possible to still maintain a high level of protection. So we brought this feedback to the work group, and based on this, the work group decided to incorporate revisiting the adolescent schedule into our work plan over the next about 15 months. And there's a number of reasons that we are planning to spread this evaluation out over that time frame, rather than trying to push to accomplish this more quickly. These reasons include, first, ensuring that we have adequate time to complete and fully evaluate the necessary grade and ETR assessments, including addressing questions about cost effectiveness and the importance of the booster response for what is currently the second dose of MenABCWY vaccines for protecting older adolescents. Assessing the extended interval data for pentavalent vaccines administered more than a year apart, which we anticipate will become available at some point next year, and will open up new options for spacing of meningococcal vaccine doses. Making sure we have plenty of time to integrate the recommended changes into the overall child and adolescent immunization schedule in a way that will be clear to clinicians, and ensuring that we can fully consider an additional year of post-COVID epidemiology, which we feel is particularly important in light of the new meningococcal strains in the US that are primarily affecting Black and Hispanic populations and so have substantial implications for health equity. So obviously, there are many different ways that the adolescent schedule for meningococcal vaccines could be altered, but based on the discussions at the last ACIP meeting and with the work group, we plan to focus on these core questions. So first, should the MenABCWY series recommendations be changed to begin at an older age than currently recommended, or to either eliminate the 11 to 12-year-old dose of MenABCWY entirely or change the recommendation to shared clinical decision-making? Second, should we adjust the MenB series recommendations to alter the recommended ages or dosing interval to provide better protection for individuals aged 18 to 19 years? Or should we revisit the shared clinical decision-making recommendation for some or all adolescents, for instance, to better reflect the higher risk among adolescents who are planning to attend college? And finally, throughout this process, we hope to think through whether there are ways to better integrate the MenABCWY and MenB vaccine schedules to streamline administration and increase feasibility for providers. So our tentative timeline for addressing these questions over the next 4 ACIP meetings is shown here. In February, we plan to return to the committee, recognizing that there may be a number of new members at that time, with more detailed terms of reference for addressing the schedule change. In June, we hope to present to you epidemiologic analyses that are relevant to possible schedule changes, including understanding the burden of disease currently averted by the MenABCWY dose at 11 to 12 years, assessment of racial and ethnic differences in disease burden among adolescents, an analysis of the risk factors for serogroup B meningococcal disease among college versus non-college students, an update on breakthrough meningococcal disease cases in vaccinated individuals to inform our thinking around duration of protection for the vaccines, and tentatively extended interval data for administering 2 doses of pentavalent vaccines several years apart, which we hope will be available by that point. In October, we'll plan to cover the grade and ETR assessments for proposed changes to the adolescent schedule, as well as cost effectiveness analyses, and then we hope to have a vote the following February. So finally, I want to highlight that we also anticipate addressing upcoming policy questions related to an additional pentavalent vaccine, for which we do not yet have a set timeline. So we are hoping to remain somewhat flexible to ensure that we can appropriately integrate review and discussion of this additional pentavalent vaccine with the broader schedule change discussion. Okay, that's all. I just want to acknowledge the work group members and CDC contributors, and happy to take a few questions. Thanks.
Thank you, Dr. McNamara. This presentation is now open for questions. I'll just remind members to please raise your hands in the Zoom. Thank you, Dr. Daly.
Yeah, thanks so much for that, and thanks for sort of revisiting it in the big picture. Is there, this is a bit of a subtler, nuanced point, but is there, and it's in one of your slides around streamlined administration, is there an ability to look at competing priorities And by that I mean the schedule is increasingly complex. It's challenging for providers to know what to stock. So imagine if you're in Dr. Lair's practice and you're immunizing birth to older age, family medicine practice. How much is there competing priorities? If you go with one particular schedule, it takes away from other things, and I'm not articulating this for real. The complexity has negative side effects, which are that you have other things you can't do or stock, or let's say Dr. Lair's out of the office that day and they have a new MA or LPN. And so is there benefit and simplification that then translates to other vaccine preventable disease? And is that a factor in the work group deliberations, the complexity of the schedule and what you stock? And can that be considered in the work group work?
Sure, thank you for that question. So to me, the things that you're saying likely fall under sort of the feasibility area of the ETR framework. So I definitely think there's a place for considering those in the work group deliberations. I would really welcome if you or others have suggestions on, places that we could get data or evidence about, that might be relevant to how changes in the meningococcal vaccine schedule could affect, sort of the overall feasibility in clinic, because I think that's where we often struggle. Like we all know complexity is bad, but understanding exactly what the implications are can be challenging.
Yeah, I mean, just to follow that, I think, sorry.
Oh, sorry, go ahead, Dr. Daly.
Number of different products that you can stock. Can you switch from one product to another? And how complex are those decisions about who should be vaccinated in an environment where you have clinical decision support and in an environment where you don't?
Thank you. I'm hearing that we're going to need larger and larger refrigerators to stock all the different vaccine products. Dr. Talbot.
I feel like we're doing this out of order. We're going to reevaluate in a few months. And so we're going to reevaluate the schedule in a few months. And so it seems kind of funny to vote for a new vaccine and in a few months change the schedule and then have to reevaluate this vaccine. I think if we could wait to reevaluate the vaccine, when we want to give it, how much is needed, then this vaccine will fall into place a little bit better and our decisions will be clear and less complicated for the primary vaccinators out there. I feel like if we make a decision about this vaccine and in 3 months change the age, change what we think about this vaccine, I don't think it's going to help immunization rates. So I know it's not time for me to do this, but I would, I'm going to anyway, I would say we don't vote on this vaccine until we know what schedule we're going to use. And I don't know that we're in a hurry to do this because we currently have vaccines to cover these pathogens.
So if I could just respond to that, I want to say I certainly agree that you have a good point, and that's why we've actually framed, that's a big part of why we've framed the PICO questions for the pentavalent vaccine the way we have, as just whether it can be swapped in, basically, as part of our existing recommendations. So the idea is not to be changing any of the existing recommendations for the ACWY or B vaccines at this juncture. It's just letting people know whether they can use this pentavalent vaccine in lieu of already recommended doses, because we very much agree it wouldn't really make sense to kind of have new recommendations for this vaccine and then change recommendations again in a few months. So this is very much intended to be maintaining current recommendations, but saying when this vaccine could be used instead of current doses. That was the idea.
I guess my question is, what's the hurry? In COVID, there was a hurry because we had to get a vaccine out because people were dying right and left and our hospitals didn't have enough rooms and staff and ventilators. But this is not a hurry. We have perfectly good vaccines to prevent meningococcal disease. So I don't feel like we need to do anything today. If someone could explain the hurry to me, that would help.
So I defer to the ACIP Secretariat on this, but I will just say that the vaccine was licensed last week. So it's licensed, and typically vaccines are evaluated at the vote after they're licensed. But I defer to the ACIP Secretariat on whether there's truly a hurry.
Well, it will be up to the committee about whether or not there's a vote, because one of you is going to have to make a motion and it's going to have to be seconded in order for us to move forward on a vote. I think, just to follow up on Dr. McNamara's comment, I think the intent of this proposal is to provide a recommendation for use of a licensed vaccine in the context of the current schedule, which you all are going to vote on tomorrow. And it's not new recommendations. It's using a licensed vaccine in the context of our current recommendations. If we're going to change the recommendations, that clearly is a longer conversation. It's going to be a while. But in the meantime, if providers chose to use this recently licensed product within the context of our current schedule, if you all vote, it'll provide that guidance.
I'm actually going to go a little bit out of order and call on Ms. Arthur.
Thank you, Dr. Lee. I will remind the committee that because of the Cures Act, which was passed a few years ago, there is actually a statutory obligation that new licensed vaccines be evaluated and voted on relatively close to their licensure at the nearest ACIP meeting. So I'll just put that out there as one data point for the committee to consider.
Thank you. Dr. Kimberlin?
David Kimberlin, AAP Red Book. This is my own personal view. I think it's good that the committee over the next 18 months or so will be, or the work group rather, will be evaluating the meningococcal schedule. I think it's always good to look for ways that things that evolved over many years could be streamlined and perhaps improved upon based upon current data. My one recommendation would be to try to avoid shared clinical decision-making recommendations. Increasingly, I'm hearing from providers out in the field that these don't really help. I mean, if after 18 months, the work group can't make a decision, how's a private practice pediatrician supposed to do the same with much less information and much less time to really do the deep dive than the experts, ACIP members, were able to do? So that would be my one plea.
Thank you, Dr. Kimberlin. Ms. Howell?
Yes, Molly Howell, representing AIM. I also think it's great that the work group is looking at this. I just want to encourage the work group. I know ACIP doesn't determine immunization requirements for school. However, there are many states who have, 7th grade requirements or requirements around meningococcal vaccine for 11 to 12-year-olds. And so if this change is made, it would then require all states probably to change legislation or rules. And so I just hope that the work group has some discussion around that when they're thinking this through. Thank you.
Thank you. We're going to move over to Dr. Long.
Yes, thank you. I tend to agree with Dr. Talbot that it will be hard for us to talk about the current vaccine. I tend to agree with Dr. Talbot because everything will be flavored that we say about this vaccine by what we think about the schedule and the use of meningococcal vaccines at all. But maybe we should table this discussion now until at least we hear the cost effectiveness, because that may alter what we want to do also.
She's not supposed to do that either.
Thank you, Dr. Long. Dr. Paling.
First of all, I want to say thank you. The work group has really spent a lot of time thinking about what is the most cogent and efficient way to move forward. And I very much respect the question because the question's really about, do we have all the information we have? We don't have all the information we would like, but we do have enough. I'd like to make the argument we have enough information to make the decision today. And with the FDA's approval of this vaccine, no recommendation means that people are going to have to make up and decide what they're going to do with no guidance. And in my opinion, it would be better to have the ACIP guidance.
Thank you. Ms. Arthur, I think you might have to mute.
Sorry.
Thank you. We'll go to Dr. Freihofer.
Sandra Freihofer, American Medical Association. This is a comment that was triggered by Dr. Daly's comment about competing priorities, complexity, and storage challenges. And as we have more and more vaccines that are recommended, I would encourage the pharmaceutical companies to make small quantities of vaccines available for purchase rather than making a minimum of tens, hundreds, thousands of doses. That would increase access to vaccination.
Thank you. Dr. Long, your hand is still raised. Would you like to make another comment? Okay. Thank you. Are there any other questions? All right. Thanks everyone for the questions and Dr. McNamara for the presentation. Next, we'll move on to Dr. Ismael Ortega-Sanchez, who will be discussing the economics of the potential pentavalent meningococcal conjugate vaccine.
Good morning. I hope I will not make the things more difficult early this morning talking about economics. My name is Ismael Ortega-Sanchez. I'm a senior health economist at NCIRD CDC. Today I will attempt to compare and summarize key elements and findings of two economic models on the use of pentavalent vaccine for the prevention of invasive meningococcal disease among United States adolescents. In the last 8 to 9 months, the two models were updated several times. They were also discussed in extenso in the meningococcal working group of the ACIP. The first of these studies has been conducted by Pfizer. Pfizer is the manufacturer of the pentavalent vaccine that we're going to be discussing today. I will refer to this as the Pfizer model in dark blue. The second is a CDC analysis, and I will refer to this as the CDC model in light blue. For full disclosure, I have led the team conducting the CDC model. The three policy questions under analysis by both models are listed here. In general, they want to answer if the new pentavalent vaccine should be considered as an option for the quadrivalent and MenB vaccination in people currently recommended to receive both vaccines. The starting point of the two economic models are the policy questions regarding potential recommendations for the use of pentavalent vaccine in adolescents. To consider the economic of each policy question is to consider simultaneously the health benefits and costs of vaccination. Namely, is vaccinating adolescents with pentavalent vaccine series to prevent invasive meningococcal disease incrementally cost-effective relative to the use of quadrivalent and MenB vaccines? To address this question, the two models use the same comparator, the standard of care, and I'm going to be discussing a little bit more about the standard of care, but I think it's very well in your minds, and focus on analyzing the incremental cost effectiveness of vaccinating healthy adolescents 11 to 12 and 16 years old with pentavalent vaccine relative to using only the quadrivalent or the MenB vaccines. On the first left-hand side on this slide are described the current meningococcal quadrivalent and MenB recommendations. As I said, we will refer to this as the standard of care. While on the right-hand side are described three strategies with either 1 or 2 doses of the new pentavalent vaccine in combination with the existing vaccines or standing alone. For simplicity, these strategies were labeled using the initials of the vaccine and serogroups containing in the dose, the P for a dose of pentavalent, Q for a dose of quadrivalent, and B for MenB. I would recommend to keep present this notation and labels to identify the strategies during this presentation and forward. To have a vision about the comparisons of incremental analysis included in the two models that we are going to be comparing today, this slide describes the alignment of this incremental cost-effectiveness analysis with the policy questions aimed to answer. An important and recurrent detail in this presentation is the price of a dose of pentavalent used as input in the specific incremental analysis, and I want you to pay attention to the column on the right-hand side, please. I will ask you to keep present this distinction. The policy questions have important implications for the three groups of elements included in the models. The comparison of the two economic models will focus on how appropriate is the selection of modeling approach, the inputs, and the assumptions, especially those that are strong influential assumptions. These are the elements that we're going to be talking today regarding the analysis, the two models. In general, the two models follow similar designs, namely the two use a static analytical decision-making approach, rely on probabilistic or deterministic sensitivity analysis to manage the various data uncertainties, model hypothetical 11-year-old cohort in the United States that corresponds to the population, and the time frame was defined as the first 15 years after 11 years to account for the vaccination schedules. They also accounted for the loss of income associated to temporary productivity loss and to premature mortality associated to meningococcal. Once the modeling strategies were set, the two models were fed with different types of input data, and these are the input data that are going into the core of the model. Across models, the sources, specific values, and assumptions of these parameters have some overlaps, but they were marked differences as well. For the consultation of the ACIP members, the full input list could be made available. Back to this slide, in the boxes are listed the standard outcomes estimated and reported by the two models, but we will mostly talk about the cost per quality save or the incremental cost effectiveness ratio. To make the comparisons, in the following slides, we will briefly review the input data used in the model. This is the list of the input data that we're going to be focused on, basically on the cost of the vaccine, the invasive meningococcal disease incidence for pre-vaccine and vaccine era, the initial vaccine effectiveness, and waning over time, and the other inputs listed here. I want to mention that starting in this slide and forward, to specifically identify changes and updates from the dose presented last June in 2023, the text will appear either highlighted or with the word updated at the top of the slide or table. This slide describes various changes in the vaccine price as reported by Pfizer. Specifically, from March to June to 2023, Pfizer submitted various technical reports using the pentavalent vaccine price of $240 with a range of $230 to $250 per dose. In August 2023, Pfizer submitted a new technical report updating, among other elements, the pentavalent price to $250 for the private and $187.50 for public. In October, Pfizer submitted a newer technical report updating the pentavalent prices for strategies using two doses for pentavalent to $210 for the private sector, $157.50 for public sector. While the strategies with the single dose of pentavalent, the price remained at $250. This distinction will be very important when we're going to be analyzing the specific outcomes estimated in each one of the models. Regarding the various components of the vaccination program, beyond the price per dose, we can see that there are a number of elements here introduced in this table. Vaccine costs were differentiated based on the 2023 public and private sector prices and vaccine administration settings for those vaccines that are available that are already in the schedule, in the vaccination schedule. Ranges are estimated from public and private vaccine prices as well as the cost of the administration by site. In the case of pentavalent, as I mentioned in the previous slide, it was calculated using the hypothetical range of prices as released by Pfizer for the pentavalent in August and in October. Although not included in these costs, in the CDC model, rates of cost of moderate and severe adverse events were taken into account using publications in the literature. Only CDC model considers vaccine wastage for either open vial, mishandling, or updated shelf life. That's another component that comes to be very significant, significant in the total estimation of the vaccination program costs. In this slide, we show the marked difference in disease incidence for serogroup contained in the vaccines during the last years as available in the data for ABC core surveillance and the National Notifiable Disease Surveillance System. Rates of invasive meningococcal disease remain relatively high in late adolescents, but in general, rates have been declining for all ages. Overall, the incidence rates are 1/6 of those from recent pre-vaccine era. This slide also shows marked difference in how this incidence data was included in the models. The CDC model uses an age-by-year invasive meningococcal disease incidence data showing the peak in the late adolescent years, while Pfizer model uses only 4-year averages. Moreover, Pfizer extrapolates those average rates from the late adolescents to the early 20s. This approach may underestimate the incidence in teen years and overestimate the incidence in early 20 years. The initial vaccine efficacy determined by vaccine dose, and serogroup are critical data inputs to assess the vaccination impact of individual strategies. Value and assumptions on initial protection are based on various sources. For the pentavalent, it is based on the phase 3 non-inferiority initial vaccine efficacy by a single dose at 11 to 12 years old and a second dose at 16 years old of a pentavalent vaccine as reported by Pfizer, and that is reported as data on file. For the quadrivalent as well as the MenB, the initial vaccine efficacy are based on effectiveness surveillance, and the reference are there. One of the key assumptions following the initial vaccine efficacy is the one related to the duration of protection. This assumption was differentiated by serogroups containing the vaccine. Assumptions on residual protection are more conservative in the CDC model. As you can see, that there is a fast decline in the waning, showing the waning of the vaccine protection in the CDC model for both the quadrivalent and MenB vaccines. Whereas for the Pfizer model, there is an assumption based on the seroprotection to persist about 4 to 5 years for a single dose of quadrivalent of pentavalent based on the HSBA serobactericide from Pfizer clinical trial report. In the CDC model, the duration of protection for pentavalent vaccine is assumed to follow quadrivalent vaccine, while the duration of protection for MenB for a single dose and 2 doses is also for the pentavalent is assumed to be following the MenB vaccine. The pink shaded areas, and that's one important element here, denotes the higher level of uncertainty of the waning assumption beyond available surveillance of phase 3 data. As you can see, the CDC model tries to minimize the inclusion of that uncertainty into the model, whereas in the Pfizer model, there is still coming out with substantial protection that also will influence the estimates in the end of the cost-effective analysis. As in previous analysis models use % of survivor cases with a specific sequela as reported in the literature. Pfizer model reports a larger number of long-term sequela, though some with 0 value or close to 0 probabilities. Over the range of those survivors with sequela is approximately 28% of those who suffer some sequela, some long-term sequela in the Pfizer model. The CDC model focused on the most common long-term sequela among survivors of meningococcal disease infection, for which reliable data totaling totaled a smaller probability of survivors with sequela, which is approximately 21.6%, as you can see on the right-hand side. The case fatality rate, however, although they seem to be very close, the 12.5% in the Pfizer model and the 12.3% in the CDC model, although there is a differentiation by age group in the Pfizer model, there is a difference. The difference in the methodology is that in the Pfizer model, they include life years lost at the end of life for those with sequela that were included in the Pfizer model, which means that for a specific sequela that happens, for example, multiple amputations, there was a reduction in life expectancy that was accounted as the life years saved by the vaccination program. In this slide, regarding the medical costs and the quality scores, this slide shows differences in input values and approach. Pfizer unitary medical costs differentiate the type of invasive meningococcal disease, but in average, medical costs could be twice as much as the cost used by the CDC model. Regarding qualities scores, because meningococcal disease follows a rapid clinical course, both models estimate decrease in quality of life associated with the acute illness for survivors of invasive meningococcal disease, specifically for the cases without permanent sequela. And this is the point where there are important differences. These values are different in magnitude. In the CDC model, what is equivalent to the cost, the quality associated life days, which is approximately 46.26 days during the acute phase of the disease, is only 1/3 to 1/4 of those used for a Pfizer model for the same acute phase during the acute phase of invasive meningococcal disease. After the acute phase, in cases without permanent sequela, the equivalent quality-adjusted life days is approximately 14 to 15 days which is about approximately 1/6 value in the use of the value used by Pfizer model during the acute phase of the invasive meningococcal disease. So these differences you may be able to see that the higher these values, usually the higher the burden of the disease. And in the CDC model, the values are more conservative than the ones used by Pfizer. In this and the following 3 slides, I will present the comparison of the outcomes reported by both models for each of the policy questions. And you have to bear in mind the input data that we were reviewing in the previous slides as to understand some of these differences. Among the main results are the total net cost impact and incremental cost effectiveness of vaccination studies, namely the incremental health impact in terms of cases, deaths, and life years saved, quality of life outcomes, and incremental cost effectiveness ratios. In this slide, both address the first policy question, or the PICO number 1, namely, what is the incremental effectiveness of cost effectiveness of vaccinating healthy adolescents 11 to 12 and 16 years old with a pentavalent vaccine relative to using the quadrivalent or the MenABCWY vaccines? A very important clarification for this slide is that to make fair comparison in the two models use for both the total net cost estimates and the cost per quality save, the $250 per private for the dose administered in the private sector versus $187.5 in the public sector. These are the specific estimates, the specific vaccine prices that are used in this specific analysis. The data on the right-hand side, the curve of the probability, is provided by the CDC model, which describes the cumulative, the probability of the simulations, the cumulative probability of the simulations that were calculated in the model. And as you can see, that the 5th and 95th percentiles are on the negative side, which is showing that the results is showing that it will be cost saving, and the probability of being cost saving is very high. So there is a coincidence in outcomes here, although at a different level in terms of the total net cost. Likewise, in this slide, Pfizer aims to answer the second policy question, or PICO number 2. What is the incremental effectiveness of cost effectiveness of vaccinating healthy adolescents 11 to 12 and 16 years old with pentavalent vaccine relative to using only the quadrivalent vaccine? It's still costly, as we can see, even though the Pfizer estimate uses a pentavalent vaccine that is lower than in the previous analysis, the $210 for the private sector and the 157.50 cents for the public sector. The tornado diagram that you can see on the right-hand side is also provided by Pfizer, and the most important variables that are explaining the variability are related to the utilities and to the long-term sequela, as you can see on the top of this, and the probabilities of long-term sequela. In coincidence with the analysis of Pfizer, the CDC model also answers the second policy question. In this slide, we can see that the incremental cost-effectiveness ratio is also costly, though at a higher level, more than twice of the incremental cost per quality, as reported in the previous slide. This fact, the incremental cost being incrementally costly, is corroborated by the cumulative probability of simulations in the CDC model. Specifically, note that both the 5th and the 95th percentiles are positive. In other words, the probability is quite high that this strategy, the two doses, the P, and N, is costly relative to the standard of care. Regarding the third policy question, both models attempt to answer what the incremental effectiveness of the cost effectiveness of vaccinating healthy adolescents 16 years old and over with pentavalent will be compared to the using meningococcal B vaccine only. The estimates of both the incremental health outcomes and net costs were compared to be similar relative to the standard of care and coincide in pointing that the ICER of the QPV would be cost-saving. This fact is corroborated by the cumulative probability of simulations in the CDC model. Specifically, we can note that the 5th and 85th percentiles are negative, meaning that they are cost-saving. Remember that these estimates are provided using the updated vaccine price of $210 for the private sector, 150.50 cents for the public sector. Among the limitations, I want to focus on what factors that were considered by Pfizer and CDC model that may result in overestimating the ICER or underestimating the cost effectiveness of the pentavalent vaccine analysis standard compared to the standard of care. In the base case, both models assume no protection against non-invasive meningococcal disease. There are no indirect protection against invasive meningococcal disease of unvaccinated individuals because they use only a discrete model, not a dynamic model with herd immunity components or indirect effects. Productivity losses incurred by caregivers for long-term specific sequela are based on assumptions and partially included. Difference in key inputs among Pfizer and CDC model and the uncertainty in inputs data may explain some of the difference in the results, although it's very interesting to see that there are coincidences as well. The most important elements that drive this analysis or the difference in among these two models is the duration of vaccine protection and the medical costs, followed by the other variables listed here. It should be noted that the pentavalent price for the first question, the strategy that included the quadrivalent, the pentavalent, and a MenB vaccine, is uncertain, and the price used here is considered the minimum expected as reported by Higher. Higher prices will increase total net costs and ICERs in this case. In conclusion, in both models, pentavalent vaccine will reduce the invasive meningococcal disease burden in adolescents. In both models, strategies with one or more doses of the pentavalent vaccine will save more or equal number of invasive meningococcal disease cases. Regarding specifically to policy question number 1, the strategy that is described as the quadrivalent, pentavalent, and MenB vaccines could be incrementally cost-saving relative to the standard of care. Remember that in this strategy, we substitute a dose of pentavalent in substitution of the second dose of the quadrivalent and the first dose of MenB. Regarding the policy question number 2, which is the strategy that includes 2 doses of pentavalent and nothing else, we see that it's incrementally costly, not cost-saving, relative to the standard of care, which will be, in this case, the 2 doses of quadrivalent. Regarding the policy question number 3, the strategy that describes a quadrivalent followed by a pentavalent at 16 years old and another one 6 months after of pentavalent is likely cost-saving relative to the standard of care. About 96% of iterations in the CDC model simulation have an ICER less than 0. Yeah. Reasonable pentavalent prices and duration of protection combined with careful design of vaccination interventions with pentavalent will determine the cost and cost-saving value of the pentavalent vaccine among adolescents over 11 years old. So finally, let me acknowledge my collaborators who helped me to put together this presentation, and I'm ready for your questions.
Thank you very much, Dr. Ortega-Sanchez. This presentation is now open for questions. Dr. Lair.
Thank you for this presentation. Could you please go to slide 12? I was interested in the cost of the pentavalent vaccine for the 2-dose option versus the single-dose option. So top right, it looks like if it's a single-dose option, the QPB, someone is saying it's going to be $250, and if the other doses, the QPP or Q whatever, is going to be $210. Is this something from Pfizer, or I'm wondering where that information? So if I see someone nodding their head, this seems really odd to me that they're going to, depending on what we decide, they're going to charge a different amount, 1. And 2, in my office, there's no way they're going to tell whether I'm using 1 or 2. Yeah. And so I'm going to be buying it at a certain price, but they don't know how I'm giving it. So this just seems very odd to me as a practicing physician. Thank you.
If I can answer that, that's... Oh, yeah. Oh, definitely. I will defer to Pfizer to answer that.
Pfizer, would you like to talk about the price of the vaccine, please?
Hi, this is Don. Good morning. This is Donna Alpo from Pfizer, and thank you for the question and the opportunity to respond. A simplified meningococcal vaccine schedule, like QPP, will improve vaccination administration and simplify stocking. We commit to a list price of $210 for a QPP dosing schedule, or any combination that includes a 2-dose schedule for the Pfizer pentavalent vaccine, as aligned with our label. In the scenario of a QPB in isolation, given this does not align with the FDA-approved 2-dose schedule, we cannot commit to a price at this time. The previously shared prices of $250 private and $187.50 public per dose shared in Dr. Ortega-Sanchez's cost-effectiveness model was a minimal price for the purposes of economic modeling.
Thank you for that additional information. Are there additional questions for Dr. Ortega-Sanchez? Dr. Talbot.
Probably more for the committee than Dr. Ortega. This means if we did a QPB, we would do an off-label recommendation for the B. Is that correct? For the P and the B, because B is 2 doses.
Dr. Paling or Dr. McNamara, would you be able to respond, please?
Sure, this is Dr. McNamara. Yes, so a QPB schedule, yes, it is off-label for pentavalent and for B, because those are both licensed as 2-dose vaccines, 2-dose series. However, I think as Dr. Paling had pointed out earlier, right, there's not interchangeability between manufacturers of B components, but the pentavalent vaccine here contains Trumenba, basically that same component that is the B vaccine, and so that pentavalent and Trumenba do contain the same component, and so should be able to be used interchangeably in terms of the immune response, but you are correct, it is off-label.
Dr. Paling?
Okay, so the cost effectiveness is obviously very important to how we think about this. And so I would like to ask Pfizer for some clarification. So first of all, a simple one. How many doses are in a bottle?
A single dose.
Okay, so
Dr.
bottles are single dose. Okay, thank you. And then what I want to do is make sure I'm understanding what you said clearly. And so what I understood is the price of the vaccine would vary if we said it could be used with both Bs, if it could be used for 2 doses, then if we only said it could be used for when both vaccines are recommended. Is that correct?
Thank you again. It's Donnell. In a QPP scenario or any combination where a QPP is an option, the price will be $210 a dose. With the problem with the QPB, as we've already stated, is that it is not aligned with our label. And so we have not considered or finalized any pricing for that scenario. But QPP and any combination that includes a QPP, the price is $210 per dose.
Okay. We are planning on a vote today, and this is important. Could I ask that the group convene and come up with a price if the vote is a different way? Because that's actually an important determination. Thank you.
Dr. Cenayas.
Thank you. This question is for Dr. Ortega. Does the standard of care used in both analyses, so that's QQBB, take into account the current MenB uptake, since that's a shared clinical decision making recommendations in terms of the cost analyses?
Yeah, that's a very good question. The two models use a discrete static model. A static model, not a discrete, a static model, which means that only the direct impact are taken into account, the direct impact of vaccination. So in order to align both models, we use only a single similar uptake of the vaccines, so that there is no that variation is not included in the base case analysis. Yet we can definitely include variations in the uptake and see that will be mute to the cost ratios, incremental cost effective ratios, because whatever you are saving in terms of not given doses, you are also not saving in terms of disease prevented, and they cancel in the ICER.
Thank you.
Dr. Talbot?
Hi, this is a question for Pfizer. It's 2 parts. What is the current price for 1 dose of B? So when you give, even if you're giving 2 doses of B, when you purchase the vaccine, what is the price of 1 dose? And 2, are you insinuating that, hang on, and are you insinuating that if we change the recommendation to QPB, that you would change the price of B?
The QPB does not align to our label, so we would need to go back and consider what the price would be, given that it doesn't align to our label. However, if there's an option of QPP or any combination where the QPP or 2 doses of the pentavalent vaccine is an option, then the price would be $210 per dose.
But my question is, what is the current cost of 1 dose?
The current cost for our MenB price is $178 private and $130.77 public.
And you would consider changing the price of MenB if we did QPB?
No, absolutely not. That's not. This is the price for our pentavalent vaccine. Is the price for Tememba, our current MenB vaccine price would not change.
Thank you.
Thank you. I'm just going to chime in with my opinion, which is I actually, in this instance, appreciate the manufacturer's approach, which is, being transparent about the two-dose pricing and recognizing that if it is not as it was originally licensed for use, the need to reconsider the pricing strategy. I will say, though, that so I am not usually empathetic, but I'm empathetic in this instance. But I will say that it makes it very difficult to make a decision. So I think the tension you're hearing is more about the fact that we have to consider cost effectiveness in any of our decision making, and the uncertainty around the price makes it difficult to assess that. I think clearly we have some ranges and some sensitivity analyses, but that's where I think you're hearing the discomfort with regard to making a recommendation today. So I just wanted to be clear about at least my opinion around this. I think others may have different opinions. Ms. Good, or Dr. Good.
Yes, good morning. Dr. Ortega-Sanchez, I guess I have a question about why the PPN, which is no extra intervention, would be more costly than a QPP. I guess I'm not understanding why that sort of came out that way. If you could help me understand that a little bit more.
Yeah, definitely. Basically, as we will see in the slide, the summary one for policy question number 2, you can see that even in the analysis that presented that submitted Pfizer, we have a number of cases incrementally safe and dead safe and life year safe, but the cost is basically due to the pentavalent vaccine price compared to what is the costs of the standard of care. So that's the reason why when you use only pentavalent, nothing else against the standard of care, which will be 2 doses of quadrivalent vaccine, becomes costly. In the CDC model, we use the same analysis, although with the assumptions and data that we have been describing in the previous analysis, in the previous slides, and we come with also a costly estimate, although higher than the one that was provided by Pfizer. You can see that in the slide number 20. We have been trying to see what the simulations come up, and all the simulations, regardless of which ones are, come positive, so it means that it will be costly. And the baseline, it's more than 4 million per incremental incremental quality safe. I believe, I hope I answer your question.
Yes, thank you very much. That's helpful.
Thank you.
Are there any additional questions for Dr. Ortega-Sanchez?
I tried to.
I don't hear any, or I don't see any additional hands raised. So thank you, Dr. Talbot, please go ahead.
Sorry. If we give PPN currently with the recommendation of 11 and 12, my understanding is that would not provide B protection in college. But if we gave PP starting at 16, that would. So would that, I guess my question is, PPN is cost effective, but not for B when you get to college. Is that correct? Because you'd have to have a booster of B at college time.
Because the effectiveness of PP starting at 11 years old, PM, 2 doses of pentavalent, because of the cost of the pentavalent vaccine, and because they look very similar in terms of effectiveness, the strategy substituting the quadrivalent with the pentavalent is more costly, not cost effective, costly. Yeah. But if you are thinking of switching that into giving the 2 doses starting at 16, that's a different question. It's not analyzed in these strategies. It was one of the analyses that we were thinking of doing, but that's a different type of question.
I, for some reason, lost Dr. Ortega-Sanchez. Are you still speaking?
No, but Dr. Long has her hand up.
Okay, thank you. Dr. Long?
Thank you. I have a 2-part question. The first is, what percentage of older adolescents currently get B under shared clinical decision-making?
This is Dr. McNamara. So our last data is around 30% of 17-year-olds are getting at least one dose of serogroup B vaccine. And from other data sources, it looks like about half of those end up completing the series, maybe a little more.
And I assume that the majority of those are college students. Do we know that?
We unfortunately don't really have a good way to assess that. Yeah.
And so, you know, doctors don't like to have to stock lots of different kinds of vaccines. So the least difficult would be to do the combination vaccine. And so have you figured into this cost effectiveness model that there would be potentially a much higher percent? I assume the ACWY uptake at this age is very high. Is that correct? At this older age?
Yeah, so the current MenABCWY uptake, it's in the high 80s for the 11 to 12-year-old dose, and then for completion of the 2-dose series, around 60%. We do have some data from administrative claims sources that has demonstrated that the actual, the proportion of 16 to 18-year-olds who are up to date with our catch-up recommendations is significantly higher than that, as some people, obviously don't get that 11 to 12-year-old dose and get a dose at 16 at their first dose.
So it's very high. So have you figured in your cost-effectiveness model that the default position would be much less shared clinical decision-making and much higher percent getting the combination vaccine? Do we see that anywhere here?
Not exactly. As I mentioned before, these models are static models that include only direct impact of vaccination. So therefore, when you do this kind of analysis, the uptake is mute in terms of impact on the cost-effectiveness ratio. Yeah. So, as I mentioned before, if you are not given the vaccine, you are saving dollars, but you are not also saving the disease. So therefore, both of those values, one in the denominator and one in the numerator, they cancel. And that's why the ICERs, the incremental cost-effectiveness ratios, the cost per QualiSave, remain unchanged, not influenced by the coverage or the uptake of the vaccination.
But the unintended consequence would be extremely costly. Not to prevent more disease, but would be extremely costly.
Yeah, I'll add a little commentary if it's okay, Dr. Ortega-Sanchez, which is to say, yes, I think the implication would be that the total cost would be higher, but that doesn't necessarily impact the cost effectiveness. And actually, our ACIP charter specifically states that we consider cost effectiveness and not necessarily total cost in our decision making, for whatever that's worth. But you're totally correct, Dr. Long. Dr. Ortega-Sanchez, is there anything else you wanted to mention before we move on?
No, I think that you complemented very magnificently my answer.
Thank you. Sorry for jumping in.
No,
Ms. McNally.
That was great. Yeah.
Thank you. I am wondering if Pfizer can discuss how a shared clinical decision-making recommendation may impact their pricing decision, if at all.
Again. Oh, hi, this is Donna Alcohol, and that will not impact our pricing decision. And I do want to just reinforce, when I talk about in combination, the price, if a QPP and a QPB are recommended, the price would be $210 per dose. It's the QPB in isolation that does not align with our label, which we would need to reconsider. Thank you.
Thank you. Dr. Long, is your hand raised again? Okay, thank you. Any additional questions? All right, thank you, Dr. Ortega-Sanchez, and we will move on. Well, before we move on to Dr. Collins's presentation, I believe we do have a request for a brief statement by our Pfizer colleagues, Dr. Hodar, who just to clarify, we usually offer approximately 3 minutes. So thank you, Dr. Hodar.
Yeah, thank you. Dr. Lee, do you hear me well?
We do, thank you. You can maybe get a little closer to the mic. Thank you.
Yes, thank you. So I'm Luis Hodar, the Chief Medical Officer for Vaccines and Antivirals, and I hope the price now has been clarified. Just to make sure that there is no misunderstanding. When we are talking about QPP, we are talking about the licensed product, which is basically 2 pentavalents. I mean, administered 6 months apart, and that's how Pfizer, because there has been discussions, and I think the committee members said how important was the cost effectiveness analysis. We made an effort to be clear and transparent and give to 110. Obviously, other options, once the license options is included, other options that include a pentavalent followed by a monovalent B are at the same price. And as Donna said, it is only in the situation where this mixed schedule that it's not in the label, which is a pentavalent and a monovalent B, is exclusively recommended when the price needs to be reassessed. So I just wanted to make sure, because there has been a lot of discussions about this. And thank you for the 3 minutes. I mean, I obviously like to highlight the advantages of our recommendations with the 2 pentavalent, the quadrivalent at 11 years of age, and then followed by the 2 doses of the pentavalent Pembraya at 16 years of age, given 6 months apart. That's what we are all calling now QPP. So as I said, Pfizer developed Pembraya in lines with the CDC's general best practice guidelines regarding combination vaccines. In general, I think we all should agree that licensed combination vaccines can improve vaccine uptake, vaccine compliance, while reducing the number of injections individuals receive. So recommending 2 doses of Pembraya, the QPP strategy, would simplify the current standard of care by reducing the number of injections from 4 to 3 to help protect adolescents and young adults against all 5 serogroups. This strategy, and I think that was mentioned before as well, can accomplish this with stocking only 2 vaccines, whereas the mixed QPP strategy would require HCPs to stock 3 vaccines, the quadrivalent, the pentavalent, and monovalent B vaccines, adding therefore complexity, cost, and the potential for errors. Additionally, administration of the monovalent MenABCWY vaccine is not necessarily equitable across the US, with adolescents residing in rural areas and Black and Latino adolescents having lower coverage. We believe that Pembraya is a tool that could at least help close these equity gaps. The 2 doses of Pembraya given 6 months apart, as I said before, it's the only schedule based on the clinical data, and it's the only one that it's aligned with the FDA label. It is estimated that implementation of 2 doses of Pembraya could prevent more cases and deaths caused by invasive meningococcal disease compared to the current standard of care. The proposed QPP schedule will reduce cost compared to the current standard of care. Pembraya will cost approximately 43% less than if the ACIP and B vaccines are administered separately, and that's why we wanted to emphasize this price. In fact, Pfizer is committed to making the vaccine available at a similar price to an individual MenABCWY vaccine, thus ensuring that the FDA indicated use of 2 doses is the most cost-saving option for the meningococcal vaccine program. And just to finalize, I would like to respectfully urge the committee to take up this policy and make recommendations of the use of the pentavalent meningococcal vaccine today. Healthcare practitioners around the country look to the ACIP as experts that set the standards of practice. Silence from ACIP until 2025 will have negative effects on vaccine confidence and leave avoiding information where suboptimal practices can emerge. Recommendations from ACIP should ensure on-label use of the vaccine and will result in better real-world safety and effectiveness data over the next year. that ACIP can then use to revisit recommendation on the entire meningococcal platform. I really want to thank the committee for these complex deliberations to optimize the meningococcal vaccine platform, and we hope that the simplicity advantages and cost savings of the quadrivalent, pentavalent strategy can translate into public health benefit and accessibility to everyone. Back to you, Dr. Lee, and thank you very much for your time.
Yeah, thank you, Dr. Hodar. Dr. Kimberlin, would you be able to hold the question until the next section? Because we're running just a little behind, or is it a brief comment?
It's a question. It's two questions for Dr. Ortega-Sanchez, I'm afraid. But they're very quick.
Okay, thank you.
If you back up 2 slides to slide 18. Which is that, are y'all going to back up 2 slides or?
As they're working on it.
Yeah, there we go.
Oh, yeah, there we go.
All right. Question is SOC, standard of care. Is that QQ plus BB?
Repeat the question, please. I'm not sure I follow.
Is the SOC that's in the table, the second and third columns of the table, does that refer to QQ plus BB?
Yes.
Okay, can you go to slide 21? Same question, second and third column, standard of care. Does that mean BB?
Yes.
Or does it mean QQ plus BB?
Yes, that's the standard of care.
What is standard of care? That's my question. Is it BB in this scenario, or is it QQ plus BB?
It's a QQ plus BB. Yeah.
Okay. All right. Thank you.
Thank you, Dr. Kimberlin. And Dr. Ortega-Sanchez. We are going to move on to Dr. Jennifer Collins, who will be discussing the summary of ETR and proposed recommendation for Pfizer's MenABCWY vaccine. Thank you.
Good morning. As a reminder, current ACIP recommendations for meningococcal vaccines are shown here. Within the routine schedule, MenACWY is recommended with dose 1 at age 11 to 12 years and a booster dose at age 16 years. MenB is recommended on the basis of shared clinical decision-making with 2 doses at age 16 through 23 years and a preferred age of 16 through 18 years. Both vaccines are also recommended in certain special situations based on patient age and risk factors for meningococcal disease, as shown in the table. Meningococcal vaccines that are licensed and available in the United States are shown here. Notably, the quadrivalent MenACWY vaccines are interchangeable. MenB vaccines are not interchangeable, which we will discuss more later. Pfizer's pentavalent MenABCWY vaccine is now licensed as a 2-dose series with a 6-month interval for individuals aged 10 through 25 years. As a reminder, the pentavalent vaccine is comprised of Trumenba, Pfizer's MenB vaccine, which is currently licensed and available in the United States, and Nimenrix, Pfizer's MenACWY vaccine, which is not licensed in the United States but has been used extensively in Europe and elsewhere for more than a decade. The work group addressed the 3 policy questions listed here. 1, should Pfizer's pentavalent vaccine be included as an option for MenACWY and MenB vaccination in people currently recommended to receive both vaccines? 2, should the pentavalent vaccine be included as an option for people currently recommended to receive MenACWY only? And 3, should the pentavalent vaccine be included as an option for people currently recommended to receive MenB only? This table shows the combined policy question and PICOs. The population is individuals aged 10 years or older. The intervention is vaccination with Pfizer's pentavalent vaccine. The comparison varies by the policy question. Later, we will discuss the available data for the 6 outcomes shown here that were assessed through grade. This table shows how the PICOs were translated into schedule options for healthy adolescents for the purposes of the grade assessment and the economic analyses. Q stands for the quadrivalent vaccine, MenACWY, B for MenB, and P for the pentavalent vaccine. Recall, these options assumed that vaccinations were given first at age 11 to 12 years, when the first quadrivalent dose is recommended, with subsequent vaccinations at age 16 years, when the second quadrivalent dose is recommended. However, as discussed in June and earlier today, age 16 years is often not optimal timing for the MenB component. This table summarizes the schedule options and workgroup consensus presented in June. At that time, the workgroup was in favor of PICO 1 or QPB. The workgroup was not in favor of PICO 2 or PPB. The workgroup was divided regarding PICO 3. Since June, the workgroup has refined the ETR framework and further considered possible implications of each PICO, especially PICO 3, based on ACIP members' concerns raised during the June meeting. These include cost-effectiveness concerns about all options, including the current schedule, concerns about increasing exposure to B component vaccines related to reactogenicity, low burden of disease, and limitations to protection. The optimal timing of B component is often not age 16 years. Fidelity to clinical trial data and licensure, and stocking and administration considerations. As presented earlier, the cost-effectiveness analysis was revised to reflect updates to the quoted price of the pentavalent vaccine and to incorporate refinements to the CDC model. Now for a summary of the updated ETR. For the public health problem domain, members noted the incidence of meningococcal disease is low and decreasing, but that it causes very severe disease and poor outcomes even with treatment. The case fatality rate is 10 to 15%, and 10 to 20% of survivors have permanent sequelae. The workgroup interpretation for public health problem was yes for all three PICOs. Regarding benefits and harms, 3 randomized control trials studied the pentavalent vaccine, 2 doses at 6 and 12-month intervals, versus MenACWY CRM 1 dose, plus MenB FHBP 2 doses with a 6-month interval. The studies were conducted among both ACWY naive and ACWY primed participants. Available data facilitated assessment of select outcomes through grade as shown here. Other important benefits and harms were not assessed through grade, but factored into the workgroup interpretations. These included increased reactogenicity of MenB relative to MenACWY, and limitations to B protection, including that low vaccine effectiveness is expected following a single dose, rapidly waning protection following a 2-dose series, and multiple studies demonstrating MenB vaccination has no effect on meningococcal carriage. This table shows a summary of the grade assessment. For benefits, no data were available to assess the critical outcome meningococcal disease caused by serogroups A, B, C, W, and Y. For the critical outcome of short-term immunity, data were available from 1 randomized control trial. Serogroup-specific seroresponses 1 month after the first trial dose of ACWY or B-containing vaccine occurred as often or more often in the pentavalent group compared with the control group. The evidence type was moderate for healthy persons and low for those at increased risk. For the important benefit of persistent immunity, data were available from 2 randomized control trials. Seroresponse rates by serogroup were similar between groups as shown. The evidence type was low to moderate for healthy individuals, depending on serogroup, and low for those at increased risk. For the critical outcome of serious adverse events, data were available from 3 randomized control trials. Significantly more serious adverse events occurred in the pentavalent group versus the comparison group, though none were attributed to the vaccine. The evidence type was low for healthy individuals and very low for those at increased risk. For the important outcome of non-serious adverse events, data were available from 3 randomized control trials. Significantly more non-serious adverse events occurred in the pentavalent group versus the comparison group. The evidence type was low for healthy individuals and very low for those at increased risk. No data were available to assess the important outcome interference with other recommended vaccines administered concurrently. The workgroup interpretations for benefits and harms are shown here. For PICO 1, the workgroup interpretation was that desirable and undesirable anticipated effects were small, that they favored the intervention, and with overall certainty varying by group. For PICO 2, the workgroup interpretation was that desirable anticipated effects were minimal to moderate, undesirable anticipated effects were minimal or small, the balance favored the intervention, comparison, or both, and overall certainty varied by group. For PICO 3, the workgroup interpretation was that the desirable anticipated effects were minimal, the undesirable anticipated effects were minimal or small, with the balance favoring the intervention or comparison, and overall certainty, again, varying by group. Okay. Regarding the values of the target population, limited data were available. The workgroup noted that among adolescents during 2021, vaccination coverage of at least one dose was 89% for MenABCWY and 31% for MenB. Limited data were available on vaccine uptake in other individuals recommended to receive MenABCWY or MenB vaccine. In general, use of combination vaccines can reduce the number of injections and is generally preferred over separate injections of the equivalent component vaccines. For the first values domain question, does the target population feel that desirable effects were large relative to undesirable effects? The workgroup interpretations were probably yes for PICOs 1 and 2, and probably yes or don't know for PICO 3. For the second values domain question, is there important uncertainty or variability in how much people value the main outcome? The workgroup interpretation was probably no for PICO 1 and probably yes for PICOs 2 and 3. For acceptability, limited data were available. The workgroup noted that acceptability likely depends on the PICO and balance of stakeholder values. Healthcare providers are likely supportive of options that allow stocking fewer vaccines. Pentavalent vaccines have potential to increase vaccination rates against serogroup B disease and can reduce the number of injections from 4 to 3 for some patients. However, pentavalent vaccines also have potential to incentivize MenB administration at age 16 years, with waning immunity by peak risk for some patients. Many providers prefer to wait until closer to exposure to congregate settings such as college or the military. ACIP and workgroup members have also expressed concerns about increasing exposure to MenB component vaccines, which are more reactogenic than MenABCWY vaccines, particularly when the burden of MenB disease is already low despite low vaccine coverage. The workgroup interpretations for acceptability was probably yes or yes for PICOs 1 and 2, and don't know for PICO 3. For resource use, ACIP and workgroup members have noted that all proposed meningococcal vaccine strategies are expensive, including currently recommended options for adolescents. With the new price estimates, QPP is the most cost-effective option when MenB protection is desired. The workgroup interpretations were probably yes or yes for PICO 1, probably no or no for PICO 2, and probably yes or yes for PICO 3. For equity, limited data were available, but workgroup members felt the pentavalent vaccine is not expected to negatively impact equity. It could potentially reduce disparities among those who might be interested in being vaccinated against serogroup B, but who might not otherwise receive clinical care that includes discussion of the MenB vaccine. Workgroup members also discussed the possible risk of clinics not stocking monovalent B vaccines with some policy options, which could affect availability for outbreaks and for people at increased risk of meningococcal disease who are recommended to receive 3 doses of MenB FHBP. The workgroup interpretations for equity were probably no impact or varies for PICO 1, probably increased varies or don't know for PICO 2, and don't know for PICO 3. Regarding whether the intervention is feasible to implement, The work group felt challenges with insurance coverage specific to the pentavalent vaccine were not expected. Substantial financial burdens for providers or health systems were also not expected. The pentavalent vaccine would provide an additional option in the current schedule and may reduce the number of doses for some people. However, administration requires reconstitution, which may lead to administration errors. Stocking 3 different meningococcal vaccine types may also be prohibitive for some providers. And the lack of B vaccine interchangeability complicates stocking considerations. The workgroup interpretations for feasibility were probably yes or yes for all 3 PICOs. This table summarizes the ETR domains and workgroup interpretations for each of the 3 PICOs as I just presented. The darker blue shading corresponds with a favorable rating, lighter blue with somewhat favorable, white with uncertain, and orange with unfavorable. You can see that for PICO 1, workgroup judgments were generally supportive, less so for PICO 2 with more uncertainty, and PICO 3 had the most uncertainty. A summary of the workgroup consensus and debate regarding the PICOs is shown here. The workgroup has a strong consensus in favor of PICO 1, the pentavalent vaccine as an option for MenACWY and MenB, or QPB. They have a strong consensus against PICO 2, the pentavalent vaccine as an option for MenACWY only, or PPB. And they have limited consensus regarding PICO 3, the pentavalent vaccine as an option for MenB only. Options the workgroup debated for PICO 3 are shown in the table. Option A would reject PICO 3 outright. Option B would accept PICO 3 with limitations, allowing for QPP only. And option C would accept PICO 3 fully, which would allow for QPP and other options. This differentiation between options B and C is new since June. And in the next slide, we will demonstrate how these 3 options fit into the existing recommendations for meningococcal vaccines. This framework shows the existing recommendations for the routine schedule incorporating shared clinical decision-making. The purple Qs represent the quadrivalent MenACWY vaccines, and the blue Bs represent MenB vaccines. The horizontal alignment of the boxes corresponds with age of vaccine administration according to the x-axis scale at the bottom. As you know, the first dose of quadrivalent vaccine is recommended at age 11 to 12 years, and the second dose is recommended at age 16 years. Shared clinical decision-making, reflected by the gray box, may result in no B vaccination, shown on the lowest path, B vaccination at age 16 years when the second quadrivalent dose is given, shown on the middle path, or B vaccination at an age greater than 16 years, shown on the top path. Although this is relatively straightforward, we will see that the introduction of pentavalent vaccines adds complexity. Option A adds QPB to the existing options. That is, per the consensus in favor of PICO 1, the pentavalent vaccine could be given in lieu of MenACWY and MenB when both vaccines are indicated. Because PICO 3 is rejected with option A, the pentavalent vaccine would not be used in lieu of MenB only. The remaining MenB vaccine would therefore be monovalent. The difference between the 2 QPB options highlighted in yellow relates to the interval between the pentavalent vaccine and the subsequent monovalent B vaccine. Notably, neither option is consistent with the licensure for a 2-dose pentavalent or MenB series, and there is a lack of data regarding immunogenicity with extended intervals between B doses. Option B adds QPP to option A. That is, if an initial dose of pentavalent vaccine was given, say at age 16 years, a second dose could be given 6 months later within the licensed indications to complete the meningococcal vaccine series. Apart from this limited circumstance, pentavalent vaccine would not be used to replace MenB. Option C adds QQPP and QQPB to option B. That is, in accepting PICO 3 fully, the pentavalent vaccine could be given in lieu of MenB even after the MenACWY series has been completed. With this increased flexibility comes a higher cost and a lack of data on safety and immunogenicity of pentavalent vaccines in individuals primed with 2 doses of quadrivalent vaccine. Notably, QQPP and QQPB options were not assessed through grade. In summary, all three options considered by the work group would permit the current standard of care of QQ versus QQBB under shared clinical decision-making. Option A adds QPB, option B adds QPP on top of that, and option C adds QQPP and QQPB to option B. Workgroup deliberations regarding options A, B, and C are summarized here. For each consideration, the most favorable option is shown in the darker blue, somewhat favorable in lighter blue, and least favorable in white. Option A, yes to PICO 1 only, or QPB, is shown in the left column. Option B, yes to PICO 1 and yes to PICO 3, QPP only, is shown in the middle column. And option C, yes to PICO 1 and yes to all three PICO options, is shown on the right. At this high level, you can see option B had the most favorable ratings overall. Option B is best aligned with clinical trial data and proposed licensure and provides only one excess dose of MenACWY. It also provides intermediate flexibility to stock 2 vaccines if using the pentavalent vaccine for routine indications, assuming MenB at age 16 years. However, all options would require stocking 3 vaccines for special situations, though 2 vaccines could be stocked regardless if using only MenACWY and MenB. Option B was also the most cost-effective option based on recent price updates from Pfizer, and workgroup members felt there was lower potential for insurance reimbursement issues.
CDC ACIP meeting.
Now to the balance of consequences and workgroup interpretations. On this slide and subsequent slides, darker blue shading corresponds with a more common workgroup response, and majority opinions are represented by the orange rectangles. For the balance of consequences for PICO 1, the pentavalent vaccine is an option for MenACWY and MenB. The majority of workgroup members think that desirable consequences probably or clearly outweigh undesirable consequences in most settings. For PICO 1, the majority of workgroup members favored recommending the intervention. For PICO 2, the pentavalent vaccine as an option for MenACWY only, the majority of workgroup members thought the undesirable consequences clearly or probably outweigh the desirable consequences in most settings. For PICO 2, the majority of workgroup members favored not recommending the intervention. For PICO 3, the pentavalent vaccine as an option for MenB, the workgroup did not reach a majority consensus on the balance of consequences and were evenly split among the 3 options shown in darker blue. For the workgroup interpretation for PICO 3, we added an additional option because some workgroup members favored QPP only. Based on the shading, you can see the workgroup was divided regarding PICO 3. The majority of workgroup members favored PICO 3 in some form. However, a substantial minority of workgroup members favored rejecting PICO 3 outright, option A. The workgroup has agreed to present option B, QPP, as a compromise to the committee for further deliberation. The combined draft proposal for option B is shown here. I'll read it to you. Pfizer's pentavalent vaccine may be used when both MenACWY and MenB are indicated at the same visit as described in the footnote. If the pentavalent vaccine is administered in this way, a second dose may be administered 6 months later to complete the series. The footnote reads, 1, healthy individuals aged 16 through 23 years in the routine schedule when shared clinical decision-making favors administration of MenB vaccination. And 2, individuals aged 10 years and older at increased risk of meningococcal disease, for example, due to persistent complement deficiencies, complement inhibitor use, or functional or anatomic asplenia, who are due for both vaccines. The workgroup also wanted to include the following remarks, which are not part of the proposal language. For Pfizer's pentavalent vaccine, data are not available regarding safety or immunogenicity of dosing intervals exceeding 12 months. The licensed B component vaccines are not interchangeable by manufacturer. Administration of a B component vaccine requires that subsequent B component vaccine doses be from the same manufacturer. And the minimum interval for Pfizer's pentavalent vaccine is 6 months. Individuals at increased risk for meningococcal disease who are recommended to receive additional doses of MenACWY and MenB less than 6 months after a dose of pentavalent meningococcal vaccine should instead receive separate vaccines. Rationale in favor of the combined draft proposal include that it aligns with clinical trial data and licensure, allows for fewer doses than QQBB, provides flexibility with vaccine inventory, including for clinics that prefer to stock 2 vaccines for routine indications, assuming MenB at age 16 years. Stocking fewer vaccines may increase equity, for example, if under-resourced clinics are less likely to stock 3 vaccines, and it's the most cost-effective option based on recent price updates from Pfizer. Rationale against the combined draft proposal include that it has an unnecessary ACWY antigen exposure for the second pentavalent dose in the routine schedule, and that there's not as much flexibility for providers as option 3. General considerations against all options include the potential to incentivize MenB at age 16 years with waning immunity by peak risk, for example, college and military for some patients. Also, uncertainty regarding the cost estimates, and that if using the pentavalent vaccine, it will be necessary to stock 3 vaccines to cover all indications, both the routine schedule and special situations, which may be challenging for some vaccine providers. I'd like to acknowledge the many people listed here whose valuable contributions made this presentation possible. Thank you, and I'm happy to take any questions.
Thank you, Dr. Collins. This presentation is now open for questions. Dr. Talbot.
I need to clarify because I'm not a pediatrician. If B is a shared clinical decision making and they get Q, at the second dose, do you have to have a shared clinical decision making of Q versus P? And then after that, you have to do a shared clinical decision making for B, or you've already decided to do B if you've done P?
May I answer that as a general pediatrician?
Please.
Okay, the way I would embark in this conversation is on the second dose to say, okay, there's 2 types, ACWY and there's B. And then go through which ones are we going to do and then decide, okay, if we're going to include B, we can do it separately or we can do all together.
So if it's shared,
but it would be shared clinical decision-making for B regardless.
Yes. And so if it's shared clinical decision-making, you need to stock all 3 vaccines then. Q, P, and B.
You could say that the way we, there's 2 options. So if I am a very small clinic, I may say that the way I carry B is in a pentavalent vaccine. And if you want to get it only B, you could go probably to the health department or go to someone that I knew that carries it, is probably how I'd have that conversation. If you're in a large organization, you would probably carry all 3.
Okay, we'll move on. Dr. Long.
So we didn't decide to make this combination vaccine. This committee did not decide. The disease, meningococcal disease, is the only thing putting them together, and it would be easy to advertise this as the full meningococcal panel. But meningococcal diseases, as uncommon as they are also extremely different in that, secondary cases occur very quickly, with C and W and Y. And it's hard to recognize you even have an outbreak of B because it may be 2 cases over 3 months, or it may be 3 cases over 18 months. So it's a vaccine that's much better targeted for outbreak use because it also has a very short period for which it really provides terrific effectiveness. or I'm going to say efficacy, not effectiveness. So I think we're having difficulty. And the next part of it that makes it difficulty is we already have this schedule that's not quite right, because the prevention of B really wants to start later than the second dose of CWY. So I think it's very difficult for us to come up with very much that would be good utilization of funds and resources if we try to put these together ever. And I'm still very cognizant that we should not give one more antigen than we need to give. And although we have done that with combination vaccines, maybe for small children when they're receiving so many concurrently, it's not the case here, and I'll stop there. So I would also like everybody maybe to review Robert's rules for how we will vote, and if there can be an amendment prior to the proposal of the vote to not vote. So I would like to sort of understand that before we get to the afternoon.
I'll defer to Dr. Wharton, but I don't know if I've heard of an amendment to not vote. So we're going to move on to Dr. Nelson. Actually, Dr. Wharton, if you want to comment later, I'm happy to have you comment. But I want to make sure we get through the questions and the comments. So Dr. Nelson.
Thank you, Camille Cotton. So, sorry, I go by both names, Grace. It's fine.
Why do I do that every time? I apologize, Dr.
It's okay. It brings me back to the good old days. So as an adult provider, I don't actually want to comment on the pediatric issues, which I think are complicated. However, I do give a lot of doses of meningococcal vaccine, especially to people who've had splenectomies. I remain astounded at the number of Americans who've had splenectomies who are under-vaccinated. And in my experience, I would estimate that this is well over 80% of people who've had splenectomies are poorly vaccinated. So it would be good to offer them an easy option. Furthermore, I see people who are going to become immunocompromised, who are thinking about starting eculizumab and other similar drugs that greatly increase the risk of meningococcal disease. And although I'm excited about the opportunity to have a pentavalent vaccine, because I'm often giving so many vaccines in clinic that it becomes really onerous to the patient, and then when they have to get 2 different vaccines, or when I'm sending them to a commercial pharmacy and they have to get 2 different vaccines, it's really complicated. And now the fact that I would need to separate the pentavalent by at least 6 months, usually my patients don't have 6 months to wait, and they may not come back for a vaccine. This is really onerous and problematic. So now I would have to give them pentavalent, followed by a shorter period, if it's going to be less than 6 months, quadrivalent plus B. And so that's really messy. And can we please, please, please make vaccination of Americans a more simple process? Because as a clinician deep in the trenches, it is really challenging these days. And we need to provide simplicity. Thank you.
I'm going to interrupt Jamie and totally go out of order. Sorry, Grace, Dr. Lee. I want to reiterate Dr. Cotton's comment about please simplify and please give me vaccines for adults.
Thank you. Dr. Lehr.
Thank you all. One clarifying question, and then I'm going to make a comment. The clarifying question is, if we are voting on the pentavalent vaccine today and we make a recommendation, how is this going to affect future pentavalent vaccines? Will it be a new vote for future vaccines, or is this vote going to apply to new vaccines? And I'm not sure. Thank you.
It will depend on the characteristics of future pentavalent vaccines. If the licensed indications are pretty much the same as this, I think we could say that vote applies to future vaccines, to a future vaccine. If there's meaningful differences, though, we would bring it back to the committee.
Thank you. And then I'm going to give a slightly long comment. I'm on the meningitis work group, and I've been a strong proponent for the QPB option, When this all started, I was thinking about, well, obviously, if you can give one less vaccine, it's a great idea, but I didn't want to give extra antigens to people. And then someone brought up that there might be clinics that will actually just have a pentavalent vaccine in their office, which was like, wow, that had never even occurred to me. And there's no way that I want to give a pentavalent vaccine to an 11-year-old because I just don't think that the B is necessary. And that's why many of us voted against PICO 2. So in my mind, if we go to slide 27, this is a question about QPB versus QPP. And that's what I'm trying to make my decision on if we vote today, because that's a separate issue. I like the concept of not giving extra antigens. The cost effectiveness was an issue, is no longer an issue because they've changed the price. I am disgruntled by the way they changed the price and the way they're framing it, but that's the way it is, and we accept reality as it is. I am regularly have patients come to me say, can I do my schedule for children's vaccines on a different schedule? And I say, yes, you can, but we don't have any data on that. And we have data on the schedule as it is, so I recommend the schedule as it is. And then I realize if I'm going for QPB, I'm going off-label, which is not the schedule, it's not the way it was studied. And so that's actually a significant issue for me. And Dr. Kimberlin really does not want shared clinical decision-making, but in this case, I am really not a fan of B, and I do want to make sure we always have shared clinical decision-making for B. So I'm probably going to need to have 3 vaccines anyways, because I'm going to have some people who don't want B, and I'm going to need Q, and it's just going to be complicated. So I am probably going to vote for the QPB option, but I am less starkly in favor of that than I was over the last 2 to 3 months. So thank you for listening.
Thank you, Dr. Lear. Dr. Daly?
Yeah, so I'm struggling. And I think we have vaccines that are not well matched. I mean, I'm fortunate. I'm grateful that we have vaccines to prevent these diseases, given the severity of meningococcal disease. But I think right now there is sort of a set of vaccines and a schedule that doesn't well match it doesn't quite match the epi, this question that Dr. Talbot brought up earlier, sort of, what's the downside of not making a recommendation today? I think generally I'm not in favor of kicking the can down the road. It's a licensed vaccine. We should provide some guidance. But I think it is problematic that we are reevaluating the entire schedule as we're voting, and there's this added uncertainty about cost effectiveness that's presented. I also think sometimes there's benefit of having a monovalent MenB vaccine, because what that does is that gives you flexibility to time the dose when it is most effective for the circumstance. Dr. Long said it beautifully. It's outbreaks, it's short-term protection. And so, we always need to think about unintended negative consequences, which is if there's a lot less monovalent MenB there, then you take a tool out of your toolbox. And so in that context, again, I'm still struggling, but I would be in favor of either not voting on a pentavalent use today, but I recognize that's problematic. And it's also problematic for the manufacturer because they can't plan nearly as well, okay? Or making narrow recommendations today. And by narrow, I mean, certainly I would think in favor of PICO question 1, but sort of narrow recommendations, because we're going to revisit this in the context of an overall conversation about how to best tailor the schedule for the epi and the resource use. Thank you.
Thank you. Dr. Paling, if it's okay, I just want to jump in and piggyback on Dr. Daly's comments, because I sort of have similar comment. So just hold a moment. So I wanted to express sort of the areas where I feel most strongly in this particular decision. And I do feel like the benefit risk balance and minimizing unnecessary exposure to antigens is an important one. And I think the reason it's complicated right now for us is due to the way the current schedule is set up. And again, recognizing that our colleagues have some work to do in thinking about how the post-COVID epidemiology has perhaps changed sort of what our benefit risk balance will look like. So I do recognize the need for that rigorous evaluation. I am in favor of option, oh my gosh, I can't remember if it's option A or option 1, but the QPB, but not, the way I would frame it actually is that it's a choice of a product that people can have. So in my mind, I think a pediatrician could stock, for example, QQ with shared clinical decision-making for QQ and BB sort of as the options. But if people have a preference or they want to have a product choice, they can decide to replace the QB combination with a pentavalent, so the QPB. I realize I say all this and it sounds very confusing, and I'm realizing how challenging this is going to be for our frontline clinicians. But I would frame it not as the recommendation, but rather that it's a choice for people to make, and they could stick with the original schedule. And the reason why I think that could be useful is because there are situations, as Dr. Cotton mentioned, where we are vaccinating transplant patients, and we do want protection for both. So, in those instances, I can imagine we will be giving essentially PP in those instances as an option for those high-risk individuals. And recognizing that the schedule may change, I think if we assume that the current schedule remains with an option for people to choose to do QPB as an alternative if they want to do that, and recognizing the complexities of that, they can do that. But then that gives us the opportunity to move towards a PP schedule in the future as we start to think about the ages. But one thing I did want to clarify and ask, actually 2 things. One is on slide 2 of the presentation, if you're able to go there, I think I had not realized that we had a little bit of dissonance in terms of the risk-based categories for ACWY and B. So I just want to clarify whether or not the working group can make that simple, because I think that inconsistency makes it challenging, because in my mind, I would just rather have a consistent set of risk groups. So a consistent set of risk groups, I think, would be really helpful to make this just a choice of a product. And then the second question I'll have is sort of for future vaccines, but I can hold on that one.
This is Dr. Oh, sorry. Did you want a response?
Yes,
this is Dr. McNamara. Sorry, I was just going to comment on your question about the dissonance between the ACWY and MenB recommendations. I mean, these are kind of longstanding recommendations that have reasons behind them. In people with HIV infection in the United States, the epidemiology showed really that there was a predominance of CWY disease and not B disease in that population. And similarly, travel to hyperendemic areas is largely about the meningitis belt of Africa, where there's no serogroup B. So there's sort of specific reasons for this dissonance. I do think this is something that we could look at as we look at the schedule over the next year to see if there are any other opportunities to better harmonize, though. But I'm not sure that we can make those changes today.
And Dr. Lee, if I could chime in, the reason that first-year college students and military recruits is not checked is because it says age 10 to greater than 10 years. So it's not recommended at 10. And so it's recommended at an older age.
I think to complement that, for first-year college students and military recruits, those are recommendations for people who didn't receive their MenABCWY vaccines already. They're not already up to date for ACWY per the routine adolescent schedule. But of course, for serogroup B, there's a shared clinical decision-making recommendation for the adolescent schedule. So if someone hasn't received those, they're not considered not up to date.
Okay. So now I understand. I think this is like a straight risk group versus a shared clinical decision-making where it looks blank, but it's implicit in that. Okay, thank you. Dr. Paling, you had your hand raised next.
I did, thank you. I want to say thank you to everybody for wrestling with this. It has not been easy, and the conversation is really much appreciated. I did want to make a comment that, yes, if we go for the QPP, which is including PICO 3, that does have an extra ACWY dose administration, but that has occurred with other combination vaccines. And so I just wanted to make sure I put it in the context of our current vaccine schedule. Thank you.
Thank you, Dr. Sanchez.
Thank you. Certainly confusing recommendations, and certainly meningococcal immunizations have always at least been confusing to me. But so I understand the concern for minimizing antigen exposures. Certainly we want to do that. I mean, we've heard about combination vaccines where we expose, for instance, hepatitis B to more than 3 doses. But we also do that with tetanus. And the recommendation for tetanus has been that if you can also give them acellular pertussis and diphtheria to go ahead rather than to just give a tetanus monovalent. So I think that, and we know that's safe. So I'm not that worried. I think the biggest issue is that we're also exposing to the 11 and 12-year-olds, not just the potential, if we recommend this vaccine, for the meningococcal B, but we're also exposing them to the others that really probably are needed. And so that I know that it will be a future discussion. I hope that it's had, because I think that we're exposing them to a lot of antigens there that are not needed until later. But I think that it's reasonable to offer this pentavalent vaccine if they're also recommended to receive the meningococcal B component, like it's done for college entry, and many states are requiring that as well. So I think it's a reasonable option in certain circumstances. Maybe not universally, but yes, definitely, it's certainly a viable option. And yes, it will reduce more the number of doses and injections given. My question is, what data do we have on simultaneous administration of other vaccines with this pentavalent meningococcal vaccine?
This is Dr. McNamara. Dr. Collins, I don't know if you could pull up the grade slide, which I think had concomitant administration on there.
So we do not have direct data available on the administration of the pentavalent vaccine with other vaccines administered concurrently. Can I ask the leads to pull up slide 89? So sort of the best we could do was looking at Menrix, which is the MenABCWY component in the pentavalent vaccine. This is some information from the package insert, which states that safety and immunogenicity of Menrix was evaluated when sequentially administered or co-administered with DTaP, IPV, Hib V vaccine in the second year of life, and that this resulted in lower MenA, MenC, MenW135 geometric mean titers as measured by the SBA assay. And the clinical relevance of this, they state, is unknown, since all 99.4% of subjects had a titer of at least 8 for each of those groups. But they do provide guidance in the package insert that whenever possible, Nimenrix and Texas taxoid containing vaccines should be co-administered, or Nimenrix should be administered at least 1 month before the tetanus taxoid containing vaccine. And then also from the product label, they note that 1 month after co-administration reduced diphtheria toxoid in a cellular pertussis vaccine. There were lower GMCs observed for each of the pertussis antigens, and more than 98% of subjects had antibody concentrations above the assay cutoff thresholds. And again, the clinical relevance is unknown. So this is sort of the best available indirect data that we have.
And there's no data with the pneumococcal conjugate vaccine then? Yeah, I know.
So you said with the pneumococcal conjugate vaccine?
That wasn't studied, right?
Not to my knowledge.
Okay. And so will this appear, if this vaccine is recommended, will this be in the clinical considerations as well? That it should not be administered concurrently with...
Concurrent was okay, this
post, yeah.
This is Dr. McNamara. If I could just comment, I did want to note that the licensed meningococcal ACWY vaccines in the United States, the current ones, also have some kind of similar interference with the pertussis-containing vaccines. And similarly, clinical relevance of those observations is unknown, and so there have not been recommendations to date about, not providing those vaccines concomitantly.
Thank you for raising those issues, Dr. Sanchez. Dr. Talbot.
One quick comment and one question. I greatly appreciate the need to review FDA-approved vaccines quickly. I think that allows us, or kind of kicks us in the tail, to quickly review vaccines that are coming to market. In the cases such as RSV and COVID, that was critical. I think in this instance, it's a diversion. I think it has diverted us away from actually reviewing the meningococcal guidelines first, and it's been nothing but a distraction. In that vein, at the risk of having everyone on the meningococcal work group angry with me, is it possible to accelerate the planned review of the guidelines so that we could vote in June instead of later? Oh, Dr. Paling, you're rotating off, so you don't get to make that decision.
This is Dr. McNamara.
Go ahead.
Yeah, I'm not sure that any of us who are currently working with the meningococcal vaccines, we're currently, as you know, Dr. Crow was the former meningococcal work group lead, and we're still getting a permanent replacement. So I'm not sure if any of us are qualified to comment on that to a certain extent, if Dr. Paling is not. But I will say, we thought about this extensively, and we do think that we do think that there's quite a lot of work to do for reviewing the adolescent schedule. And one thing that we highlighted is that we do anticipate some extended interval data for pentavalent vaccines administered, 3+ years apart to become available over the next year, but we don't know exactly when that's going to be. We think that information is really important for looking at different vaccine schedule options. And so I think, I will speak for myself personally, I guess, that I would be hesitant to change the schedule in advance of having those data because I don't want to change the schedule twice. So to me, that's one important consideration.
Thank you. And I am, as chair of ACIP, going to, recommend that we have a vote. You can choose in your vote not to make the recommendation for a vaccine, but I still think that a vote needs to happen today. So, but I think you can express your preference through the vote. Next, we'll move on to Dr. Lair, and then I think we are going to have to close up this session very soon.
So one comment and then one moving forward. My comment is I actually didn't thank the manufacturer. It is actually nice to have an option that when both vaccines are approved and recommended to be able to give one as opposed to two, and that is good for patients. It's also nice to have an option that it's a safe and effective vaccine. It works. And so I do want to thank the manufacturer for presenting this and making it available to us. For Dr. Wharton, for Robert's Rules of Orders, would it be better to make a motion for a vote and then have someone try to table it, or is it better to make a motion to table it first?
So we can't table it if it's not been moved.
Correct.
So, my recommendation would be if there's a committee member who wants to move this toward a vote, they make a motion to that effect. If it is seconded, then if someone wants to amend the recommendation, they could make that motion. And then the debate would be on the motion rather than, would be on the amendment rather than the original motion.
Okay. Then I would like to make a motion in favor of slide 35, combined draft proposal for option B, and move that that language be accepted by the ACIP.
It's slide 38, if you could.
38, my apologies.
Thank you, Dr. Lair. We have a motion on the floor. Would anybody like to second the motion?
I can second.
Thank you. I heard Dr. Sanchez second the motion. So it's been moved and seconded that we adopt this recommendation language on the slide. Actually, can I ask our CDC colleagues if they could just read the recommendation as it's intended? So there's a lot of commentary on the slide, and I just want to make sure I understand what the recommendation is.
Sure, this is Dr. Collins. So Pfizer's pentavalent vaccine may be used when both MenACWY and MenB are indicated at the same visit. That would be for healthy individuals aged 16 through 23 years in the routine schedule when shared clinical decision-making favors administration of MenB vaccination, and 2, for individuals aged 10 years and older at increased risk for meningococcal disease, for example, due to persistent complement deficiencies, complement inhibitor use, or functional or anatomic asplenia, who are due for both vaccines. And if the pentavalent vaccine is administered in this way, a second dose of pentavalent vaccine may be administered 6 months later to complete the series. Would you like me to read the remarks as well?
No, thank you. That's perfect. Dr. Talbot.
I would like to make a motion to make an amendment. Did I say that correctly? I want to make an amendment, yes. And this is my amendment. Is to postpone this vote for the pentavalent meningococcal disease vaccine until after reevaluation of the current meningococcal guidelines, as we currently have adequate vaccines to cover all of these pathogens, and to reduce the complexity and the number of vaccines that need to be in a provider's office. That might be able to be shortened.
Yeah, that was a very long amendment. So the amendment is to defer the vote. This motion is currently on the table. It would be helpful to have actual wording around this if our colleagues can put this on, but I want to ask before we do that, as we do that, would anyone like to second that motion?
Dr. Long, I'll second the motion.
Okay. It's been moved and seconded that we table the vote for the first motion that was put on the table. So we are going to have to first vote on the amendment, and then we're going to have to vote on the, depending on how that amendment goes, we'll go back to the original. Okay. Any other comments or questions as it relates to this part of the vote? Because we do need to move on to the VFC section. And I will say that we will have additional discussion in the voting section of today's meeting. I'm going to call on Dr. Long and then Ms. Arthur.
We have a long history in ACIP of not, I'm about to be signed out. We have a long history of difficulty in rescinding anything or decreasing antigens or vaccines. So I think that, I mean, think about it. Maybe when we look at the whole schedule, we'll decide these vaccines, I'll call them the two, CWY versus B, should be separated by age group and indication. But we already have changed the architectural plan just a little bit today to approve a combination pentavalent vaccine. And if we then change those, we'll have to say, well, we have something currently licensed and recommended in an odd way, but recommended, that would be moot because most people wouldn't receive these two vaccines at the same age or indication. So I think, you know, when you change incremental and you're planning on potentially discussing and change big, you shouldn't do the incremental first. And I would speak against the prior proposal, and that is not the narrowest indication for use of the pentavalent vaccine. The narrowest indication would be to use it only when both are recommended, and that would be just for the second dose of CWY.
Thank you. Ms. Arthur, please go ahead.
Just a clarifying question. So if this would pass, how long would the delay be before there would be a vote? If I understood correctly, the working group is considering some data and important issues around the adolescent schedule, which could mean no vote for this product for 12 to 15 or more months. I want to make sure that it's clear. I'm not completely sure I understand what deferring means in terms of a licensed product waiting for a recommendation from the committee. And I would ask if that could be clarified.
Dr. Collins or McNamara?
This is Dr. McNamara. If the intent is to table the vote on this question until after we have had new votes on the adolescent meningococcal schedule, as I presented earlier, we had discussed with the working group having that happen in February of 2025. So that would be my default assumption, I guess, for when this would occur. Obviously, nothing is set in stone, but as I commented earlier, I do think reassessing the schedule will take a significant amount of time.
Right.
Thank you. Dr. Brooks?
Yes. I don't feel that we can delay the vote. I speak against the amendment. It is, as Dr. Long said, we didn't ask them to make the vaccine, but they did. And like Dr. Lair said, that thank you for doing it. Because if we look at the screen right now, the work group was strongly in favor of PICO 1 and strongly against PICO 2. So if there's any concern or question, the simple thing would be vote against PICO 3 and just go with one, which is obvious. Like, if both are needed, then it's, use it. And that's incremental change, but it doesn't really commit us to anything that we're even debating. The debate is shown right there. And that would be simple, and then we'd be done. And we also have a history of making tough decisions. That's what the ACIP does. It's gotten tougher every meeting, and here we are again. I thought PCV was difficult, and that was a long time ago. So I think that for me, I speak against the amendment and this particular option right here, though I was hedging on PICO 3, but in this discussion, it makes it easier for me to just vote in favor of what's on the screen right now. Over.
Thank you. And, I don't know if you're asking for an additional amendment, but I'm going to ask Dr.
No,
Wharton
I
if she
wasn't
could.
asking for additional.
Okay.
I just spoke against the amendment that was stated earlier.
Okay, thank you. Dr. Sanchez.
What? Okay, I'll speak. No, so I'm against, I fully understand that, and I certainly want a revisit of the meningococcal schedule, at least in children. But knowing that that's going to be some time off, we have an approved vaccine or by the FDA, and it is available, and there are circumstances that children will get both vaccines, the B and the quadrivalent. So it makes sense to me to make it available under certain circumstances and under certain recommendations, rather than just table it for some future change. It just makes sense that it's available, and let's make some recommendations without adding anything more to already a complicated schedule. So I would be against the modification. Thank you.
Thank you. Dr. Daly?
This is a point of rules. So Dr. Brooks is talking about this option that's up on the screen now. My understanding, and help me if I'm interpreting this correctly, is that we would, if we are in favor of what's on the screen now, we would need to vote down the amendment, but then also vote down the first proposal, both, and then somebody would need to make a new motion for this, because this is not what we're voting on right now, correct? Okay,
Correct.
Thank you.
That is my understanding of the rules. And actually, I'm just going to chime in that I agree with Dr. Sanchez and Brooks that I think we do need to make a decision, and deferring it won't be helpful for our frontline pediatricians and family practitioners. So, Dr. Daly, to your point, I will just also speak out in favor for option A. So, but it sounds like we have an motion and an amendment on the table we need to vote on. And if anybody else would like to express their quick opinion before that vote section, I will allow for us to have more discussion just prior to the vote, so we can make sure we have the full set of options on the table. Dr. Sanchez, your hand's still raised, but I think we're going to move on unless there's anything critical. We can definitely talk about it at the vote section. We will open it up for discussion. With that, we need to move on to Dr. Santoli, who will speak to the Vaccines for Children's resolution, which might be complicated given the complexity of this vote. But Dr. Santoli, please go ahead.
Dr. Lee, should we proceed with voting on the amendment before Dr. Santoli presents VFC? I'm not quite sure how we can discuss the VFC resolution if we don't know what the motion is the committee's going to vote on.
We are certainly happy to do that. I just want to ask a point of clarification. We do need to let public comment happen before any votes. So would you like to discuss afterwards and then table that vote until tomorrow?
Okay, we can go to the VFC.
Okay, thank you.
Hello there. And we actually have prepared for the multiple options, and you'll see them reflected here. So we won't have to necessarily make a decision, but you'll see that we're able to incorporate any of the options that have been discussed, and a new option if a new option were to arise. So, okay. So what you'll notice is because this is an existing resolution, the text is going to be highlighted in yellow where there are changes, and the existing text of the meningococcal resolution that we're not proposing to change with this discussion is shown in white. Okay, so the purpose of this resolution is to update the resolution to add a new component to the VFC resolution to reflect a newly available combination meningococcal vaccine that can be used to prevent meningococcal disease attributable to serogroups A, C, W, Y, and B, and to make minor updates to the existing components of the resolution for MenABCWY component and the MenB component. Thank you. So here for the MenABCWY component, there are no proposed changes to the eligible groups. Next slide. For the recommended vaccination schedule and intervals, there are 3 changes. First, to remove Menactra, which is no longer available as an option. And then second, to remove a footnote that was used to add Menveo 1 vial to the VFC resolution when that vaccine was licensed as an alternative product to the products that were already part of the resolution. Next slide. There's no changes on this slide for the dosages or contraindications and precautions. Next slide. For the meningococcal B component, the change to the eligible groups was to actually reference shared clinical decision-making because it wasn't referenced initially, and it is referenced in the new proposed component. And so for consistency, we added that to the second bullet here under eligible groups. Next slide. Here we have added a statement to the recommended vaccination schedule and intervals table that was missing from the original resolution, where it makes clear that MenB vaccines are not interchangeable by manufacturer, and we've added a footnote. Next slide. There's no changes to the recommended dosages or contraindications and precautions. Next slide. So now what you will see, and we won't go through this in detail, I think, but I want to make sure that you understand that it's here. We have laid out, and I did not do it in order, but for option B for this new section, there is an eligible group section which mirrors what you have been discussing. Next slide. There's also a recommended vaccination schedule and intervals. Again, this mirrors what you've been discussing. But as I take you through the other options, we've highlighted the areas that are different in the resolution to acknowledge the difference between the options. So if we go to the next slide, for option A, there is not a change to the eligible groups. Next slide. There is, however, a change in the recommendation or the resolution's coverage of a second dose for children who are not at increased risk. And you can see here that this clearly indicates a monovalent, which was not the case when we were looking at option B. Otherwise, option A and option B in the resolution are the same. Next slide. Option C, which we really haven't discussed, and I don't need to go over in detail, actually has some additional changes because it acknowledges the use of this combination when MenB alone is recommended. And so that is reflected here. Next slide. It's also reflected in the recommended vaccination schedule and intervals. Next slide. This is just a statement that indicates, as we always do, that when there's a published recommendation, the information is incorporated by reference. Next slide. But I actually am recognizing that I'm missing some slides for contraindications and precautions. So I will get that added in. There would obviously be contraindications and precautions and dosage for this component as well, and they will be added prior to me bringing this forward again. That's all I had to share. Thank you.
Thank you, Dr. Santoli. May I ask for a motion for the VFC resolution, recognizing that that will depend on the final wording and the final vote of the initial recommendation?
I move to accept the language as presented based on the final vote later this afternoon.
Okay, thank you, Dr. Lair. Dr. Daly.
I second the motion.
Thank you. And thank you, Ms. Plata. All right, it's been moved and seconded that once we clarify the initial vote, that the VFC resolution be consistent with the recommendation that is given later today in our voting section. Is there anything else before we go to break? Dr. Long.
Yes, after listening to my colleagues and understanding that there is not support for tabling this, I would request to withdraw my seconding of the motion to table the vote.
Dr. Wharton, I'm just going to ask for a clarification from you.
Yes, we can do that.
Okay. Thank you. So we only have a motion on the table. We no longer have a second to the motion to table the first motion. Is there anybody else who would like to second that motion? Okay, so the amendment does not pass. And we would return to the first initial motion on the table put forward by Dr. Lair, which was option B.
So
is any other discussion needed at this time?
So I'm going to ask if any of my colleagues want to do the amendment for option A. This would be a time to do that.
A point of order, Dr. Lair, that would be, we'd have to vote this motion down and then have that option A as a second motion.
Yeah, so there's two options. So right now we have the initial motion on the table, which is option B. As Dr. Lair points out, if anyone would like to request an amendment to the motion, essentially going to option A, I think that is acceptable. Alternatively, you could vote down this one and then have another vote happen. But I actually think, just for sake of clarity, it'll be easier to have all the potential votes on the table before we go to the voting section. Maybe could our colleagues in the room please redisplay the vote options, option B and option A, so we can just be clear about what the current motion on the table is and the discussion about whether or not, as Dr. Lair points out, there is a request for an amendment. So we'll wait for option B. Thank you. So this is option B currently on the table. And then could you please move to option A? Dr. Talbot?
Yeah, I may be out of order. I just wanted to make a comment, so I guess I need to wait till the amendment goes through. Is that correct?
Okay. Well, the question is, would anyone wish to make an amendment to vote for option A? Dr. Daly?
I'd like to make an amendment to vote for option A.
Okay.
Brooks, second.
Okay, Dr. Brooks is seconded. So Dr. Daly made the motion for the amendment and Dr. Brooks has seconded. So option A, the amendment will be up first for a vote. If this does not pass, then it will go to option B. Dr. Talbot.
Yeah, a lot of my colleagues are concerned about postponing this vote because physicians will be asking how to use this vaccine. And I think that's a legitimate concern, but I think the reality is if we postpone this vote, insurance will not cover the vaccine, and so it's not a question of how to use it unless a physician wants to have the patient pay out of pocket. So I think if you're concerned about the questions by primary immunizers, the answer is We have not yet voted for it, hence insurance will not necessarily approve it. And that's your answer. So if your concern is pediatricians calling in with questions, the answer is we have 2 vaccines, actually 3, because we got 2 Bs, that are currently covered under insurance in VFC. So that would be the answer. And I don't think we need to make judgments on other people's questions or how fast the pharmaceutical company wants to push it to market. I think we need to make decisions based on what's best and what's most simple and provides the best care for our patients.
Thank you, Dr. Talbot. With that, I'm going to ask that we go to break. Again, we can reopen the discussion later this afternoon, but we will return to the vote after public comment later this afternoon. So we will take a break. We are quite behind schedule, so I'm going to ask that we just take a, let's see, for folks in the room, I think we're going to have to give you perhaps nine minutes. So 55 minutes after the hour, we'll plan to reconvene. Thank you.